Dobar dan, pozdrav svima. Pozdrav svima ispred organizacionog komiteta Ophthalmološkog simpozijuma. Čast mi je da vas vidim i da vas pozdravimo u Sarajevu. Ono što bih htjela samo da kažem da sam ja dala sign sheet na početku i ja ne znam kod koga je završio, ali bi bilo dobro da se svi potpišete jer na taj način ćemo dobiti certifikate i bodove od strane ljekarske komore. Pa sam vas zamolila da se potpišete i da ostavite na stolu kad završite. I will address my lecture in English because we have some speaker not from this region, so in order to honor them, I'll speak in English. So my today's lecture is is in oculoplastic. So we are shifting gears a little bit from myopia and from anterior segment towards oculoplastics. And I declare no conflicts of interest. My objective of today's lecture is to provide problem analysis and update of the eyelid contour adjustment and algorithm and formulas in the current literature. Ptosis surgery is considered to be one of the most challenging procedure in oculoplastic surgery. This is due to high rates of revision surgeries, of very high rates of overcorrection, undercorrection, and very hard to achieve symmetry in terms of lid height and lid contour. Historically and traditionally, when we are measuring and evaluating pre-op measurements before we are doing surgery, we usually take MRD1, which is a margin to reflex distance. And this is our main pre-op value that we use to evaluate how high we want to place the eyelid. However, other than MRD1, there are some other points that we need to take into the consideration. And this is the anatomic and physiologic elements, including the shape, height, contour, and mobility that are essential in cosmetics and functionality of the eyelid. If we do not take all these into account when we are planning our surgery, we might end up with a good lid height, but with notches, peaks, flare, and other deformities, which are part of aesthetically bad eyelid contour. So when we are planning ptosis surgery, most important measurements that we always take are MRD1, 2, and the levator function. These measurements are guiding us in choosing the type of the surgery and evaluating the lid height. And lid contour is actually the shape of the upper eyelid margin. And there are some racial and anatomical variation, and of course individual variation in each patient. Although it is assessment of a cosmesis of a periocular region, it can also be sign of some pathological condition like thyroid eye disease when we have lid retractions, especially in the lateral part. Then lacrimal expansion when we have a sinusoid eyelid shape and contour, and then some other traumatic conditions that we might take into consideration. Especially when we are doing reoperation revision surgeries, the iatrogenic alteration of the eyelid contour that every surgeon must take into consideration. Historically, we used to classify eyelid contour after the surgery as a symmetric, acceptable, good, or excellent. But that's not good enough in this point of time. So we need to strive to achieve more and be better. So this is my patient, old gentleman that I did when I was a resident. At that time, my only consideration was to give a good lid height. And I wasn't that concerned about the lid contour. And this is the before picture, and this is the after picture. And it's especially challenging to achieve good eyelid contour when we have hearing phenomenon, when we have the contralateral lid droopiness after the surgery because of the innervation of both, symmetric innervation of both eyelids. So this was a really good lid height, but the lid contour was not optimal. This is the second patient that I recently operated on. This is the before picture. He previously had 2 surgeries with elevator advancement. This is a congenital ptosis. So you can see that his lid height is not optimal. He was operated elsewhere. So he came looking like this, and the contour was not symmetrical, nor the lid height was ideal. So we performed the frontalis sling surgery, and we achieved good symmetry in terms of lid height, and I think in lid contour. In literature, there are a substantial level of evidence that are now speaking about the importance of addressing eyelid contour. However, they usually address only postoperative results. There are very scarce evidence evaluating preoperative values and how to plan the surgery. For instance, I would like to emphasize three studies. It's Danish and colleagues from 2018 that they use the mathematical calculation using the horizontal line that dissecting the middle of the pupil and 10 vertical lines 2 millimeters apart from each other. And this is how they calculated the area and the lid contour. The second study is a Cruz and al., a little bit older study, is using the points that are placed along the both upper and lower eyelid. And the spatial location of these points were represented graphically. And then the second degree polynomial function was calculated, but I think this was a bit too complicated calculation to be used in everyday practice. And then the study that also using polynomial mathematical function that is using 6 points dashes on the upper eyelid interpolated to in contrast from the normal curvature of the same age and same rational and sexual characteristic of other patients, and it's using polynomial mathematical function at the end using the mathematical software. Again, too complicated to use. Until recently, what I did in my patients, I only used 2-point suture advancement of the levator aponeurosis, and first one I would place at the mid of the pupil or slightly laterally, and then the second 1 to 2 millimeters apart from the central portion, in the lateral side. And this is what I would end up with. So this is before and this is after. And this is also before and this is after. So the lid height in symmetry was really good. But what I do not like is this peak that I'm seeing in every patient that I operated on. Sometimes it's on the central part, sometimes it's more laterally. And I've always felt that I need to make some improvement. And this is the other patient. This is before and this is after. You can see still, it's like repeating the pattern of having the good lid height, but this lateral peak that I disliked. And again here, the peak at the central portion. And again, another patient. So I came across very good evidence in the literature that they use 3-point topographical analysis of the contralateral eyelid to plan unilateral congenital ptosis. And I also use this for acquired ptosis, not only congenital. So this is the algorithm. You put the ruler on the center of the pupil, and then you calculate the first most important measurement is margin reference distance 1, and then the second measurement is medial margin limbal distance from the this edge of the limbus to the medial part of the eyelid margin, and then the lateral vertical line from the again limbus to the lateral part of the lid margin. And these are measurements X, Y, and epsilon. And then the next step is to address how much the lid excursion or lid height you want to achieve, meaning how much millimeters you want to resect of the aponeurosis or do the advancement by application. And this is H. So usually there are a lot of formulas, tables, and algorithms that you use to calculate the lid height or the resection portion that you want to excise. So usually it's between 8 and 10, sometimes 12 in acquired ptosis, and much more in congenital ptosis. And then you also have to have the common multiplier M that I will show you how to calculate. So H is the how much you want to resect, and let's say it's a 10, and then X is the margin reflex distance 1. So usually it's let's say 3.5. So you divide this and you come up with some number. And then the other measurements is again a multiplier that you multiply with epsilon. This is the medial portion of your measurement, and we ended up with 7.14. And then the lateral part, you multiply M with the set. That's a third measurement that I showed you previously, and you ended up with another number. So taking all this number into account, you then have measurements. So this is the first portion, the 10, the highest number, and then this is the second number, and this is the third number. And you place with some color or marker pen, you place these margins of the levator of the aponeurosis, and then you can do the advancement on the 3-point topography. What I changed in my practice compared to this study is that I'm not, I will go back. So I'm not doing the measurements from the tarsus, but I'm actually subtracting the numbers, the second and the third measurement from the biggest number, and I am actually calculating from here to here, subtracting these numbers, because I believe that fibers of the aponeurosis are not equally and symmetrically placed in each tarsus. There are many variations, and if you measure from the tarsus to, let's say, distally, then we might end up with non-reproducible variables. So I did a little bit of my personal adjustment, and this is the results that I gained. And this is the gentleman with both eyes, bilateral ptosis, right eye more pronounced, and this is how it ended up looking contour. Unfortunately, he also has herring phenomenon, so he will need another surgery on the left eye, but I think the contour is very symmetrical to this one. And then another patient with congenital ptosis with, again, good lid symmetry, good contour, better than previously, and no lateral peaking like I previously had. And then another girl, 31 years old female, with a very mild unilateral congenital ptosis on the left eye, and ended up with a good lid symmetry and eyelid contour. And in the end, again, a young girl, 8 years old, with congenital unilateral left eye ptosis, ended up with a symmetrical lid contour. So in the conclusion, I think that having 3 double R matrices suture based on the topographical mapping of the normal eyelid is a very good way to minimize intraoperative adjustment of the lid contour and to achieve good symmetrical gratifying eyelid contour as end-up results without need of repeating surgery and doing a lot of revision. And I thank you all for the attention.